Hello, everybody, to another episode of Meet the Greek here at the Fred Hutch Cancer Center. I'm very excited and honored to host another dear friend and colleague, Dr. Christina Baik. Dr. Baik is an amazing investigator leading our thoracic head and neck program, faculty here at Fred Hutch, University of Washington. Christina, welcome.
Thank you for the invitation.
I am thinking, time flies. I joined Fred Hutch about 8 years ago, and time goes very, very fast. And you were here when I came, and you were so kind, welcoming in. Tell me about your journey, Christina. How did you end up here at Fred Hutch, and your kind of journey in a summary?
Yeah. So I trained in East Coast, both my residency and my clinical fellowship. And in terms of my research interests, I was actually very interested in cancer epidemiology and cancer prevention field. And I did my fellowship project on that topic. And I've heard of this center in the West Coast called Fred Hutch that had a very strong cancer prevention program, and also the Center for the Women's Health Initiative, because I was really interested on the topic of lung cancer in women, and I still am. And so I, emailed the PI of that study, Dr. Ross Prentice, who was leading our public health sciences division at that time. And he actually replied to my email. That just speaks to our faculty, their really commitment for fellows and trainees. I said, I would love to come out to Seattle, do work with the Women's Health Initiative. And he invited me to be part of the Cancer Epidemiology Fellowship as a trainee, and that's how I ended up here. And that was in 2009. And then, and at that time, I was interested in it, kind of listening into thoracic medical oncology kind of case discussions and things like that. So I invited myself to some of those medical oncology meetings as a fellow, and I was invited to be a faculty in 2011, and I've been here since.
That's an amazing story, Chris. And, it sometimes in life, different coincidences and steps and initiatives can lead us forward to the journey. And it sounds you pursued that pathway, and people really, really pursued you as well. So it was a great match, and you have been doing great work. You have been the research director for the Thoracic Head and Neck program for a number of years. And, I was looking at the website, Chris. I love the quote you have there, and I will quote it here for the audience. I believe the best cancer treatment decisions stem from actively collaborating with you and your family and understanding the values and priorities, which I think is spot on. I think, patient-centered, patient and family in the forefront. Tell me a little bit more about, Chris, about this quote, what it means to you, and how you approach the patients in the clinic.
Our treatments are imperfect, right? And there's always going to be pros and cons to everything we offer. If our treatment was like an antibiotic where I know it's gonna work based on sensitivities, and there would be less discussion. But because our treatments are so imperfect, I think it's extremely important for patients to truly understand all the pros and cons. And some patients may opt for high response rates even if there's really high toxicity, and the next patient with the exact same tumor type may opt for a treatment with less response but less toxicity. So I think it's really crucial to really understand where the patients are coming from, and make sure that that we're all on the same page. And I tell patients when I discuss these treatments, I say, my goal is for you to know what I know about this drug. so that you can make the best decision for yourself.
Very nicely said, Chris. And it's important, as you said, to outline the benefits and risks of each options for the patients. And there's so much going on. In a way, it's a good problem to have more options for the patients. And you have been part of this solution to be involved in clinical trials that may lead to novel treatments and new regulatory approvals. In that context, tell us a little bit more about the clinical research that you're doing and themes that actually keeps you up at night and entertain you in the morning.
I have been very interested in novel targeted therapies in patients whose lung cancers are driven by a particular oncogene. So my clinical trial portfolio really has been in having those clinical trials at our center. So, and many of these oncogene-driven cancers are very rare, maybe 1% or 2% of our lung cancer patients, but we have to have the trials. We are the tertiary center for the region. Patients are willing to travel to our center. So having access of making sure patients have access to these novel agents in the West Coast and not just in the East Coast, that had been a very important responsibility for me. I feel a sense of obligation to have these studies here. So we have a very robust portfolio in targeted therapeutics. So that's one goal that we've had, and I think we've done a good job in making sure patients have access. On the other hand, I think where we need to go as a field, and where I would love our center to really contribute, is that we have all these patients who may not have an oncogene-driven cancer, or they do have an oncogene-driven cancer and they have gone through their targeted therapies and they're running out of options. And many of these patients are young, in their 30s, 40s, 50s. And the patients that I have currently that I'm seeing for surveillance year after year are those patients who have immunotherapy sensitive disease. And I would say in lung cancer, if we look at all lung cancer patients, only about 20% of patients have immunotherapy sensitive disease. So really trying to figure out what's going on in the 80% of patients, what are the rational treatment strategies that we can really explore so that everybody is benefiting from this long-term responses. So those are the two big themes that I'm personally working on, but not just myself. As our lung cancer research program as a whole, that's been our goal.
Thank you, Chris. And as you said, there's so many talented people in that program, and there is so much work being done, different trials, evaluating different agents. And to your point, understanding the mechanism of resistance to treatment, biomarkers of response, tumor tissue, liquid biopsy profiling, all those aspects are very important. And it's really impressive, the portfolio of trials that you guys are having. Can you give us maybe, I know it's hard to tease apart all the trials, but maybe a couple of examples of specific trials that come to mind that are open and accruing right now?
Yeah. So I can give you an example of a study that's homegrown. And so we meaning our translational team, we looked at our surgical tumor and profiled their immune microenvironment. And we've reported out on the fact that we saw 4 main subtypes. And one of the subtypes that appeared to be immunotherapy refractory is a subtype that had a lot of myeloid cells in the tumor microenvironment. So there were a lot of lymphocytes, but there were also a lot of myeloid-derived cells. And we have some data to show that if we lower that lineage in mice, that these mice respond better to immunotherapy approach. So based on our homegrown preclinical data, we designed the study where patients are receiving an immunotherapy, but also this myeloid suppressing agent at the same time, with the idea that for those patients whose mechanism of resistance is the myeloid mechanism, that will be able to really improve upon the response rate. Now, what we don't know yet is how best to identify those patients up front, and so that we can really use this strategy only for those patients. But we don't yet have a clinically validated assay to be able to identify those patients. So right now the study is in unselected patient population. But what we're hoping to do is to really go back and look at their tissue, and so that we can hone in terms of what the biomarker of response is, and so that we can design the next version of this study. So that would be one example of of a study that we're doing that is really homegrown with our own preclinical data. So that's an example of a study that we have. Another example is more it's a study that is pharma sponsored, but it's the one that I think is really important in that there are these very rare subtypes such as ALK-driven lung cancer, ROS1-driven lung cancer, um, and they're rare, but because we're a center of referral, we tend to see a lot of these patients. So we have a study of next generation ALK inhibitor and another study of next generation ROS1 inhibitor. And we're going to be the only site actually on the West Coast to have this study. We're very close to activation. And I think we can really serve our patients along the West Coast, of course, in Pacific Northwest, for those patients with those rare subtypes.
That's so exciting. And as you said, being, the site here in the West Coast, that can be very attractive to patients in the broader region. And I congratulate you for, again, giving patients the opportunity and the access to these innovative, promising therapies. And I always think about clinical trials, clinical research as an opportunity to access innovative therapies and hopefully learn, aiming hopeful to help the patient in front of us, but also generate knowledge, to your point, to help every other patient around. So it's very, very commendable that we have these opportunities. And talking about clinical research, and of course, patient care, a lot of interactions with the community, Chris, our friends and colleagues in community sites. Can you tell me a little bit more about the interactions, how you handle the referrals coming in, expedite them, and then following up with the community oncologists in the broader area?
Yeah, so when I think of community, I think of two layers. The first layer is our own institution community, and then I think of community at large, right? They may not be part of the Hutch, but they are our community, and they serve patients that we like to serve as well if there's a need. So I would say for our community sites within the Hutch, the communication is streamlined in that we have Epic, they have my cell phone, they have my email address, so it's easy to communicate. And we do have journal clubs as well, where we invite them and they've come and we know them very well, the lung cancer representatives at the community sites. And I'm also working with them in opening clinical trials that fit the community better as compared to South Lake Union, because I think the portfolio is a bit different. I think where we could do better, and I seek guidance from somebody like yourself as well, is how can our colleagues outside of the Hutch system connect to us? And I think once they connect to us, we're more than happy to work with them. But I think it's the initial step that I sometimes hear that it's hard to know who to call, who to access. And I think right now that it's more informal in the sense that I meet with them. If I see them at meetings, they have my contact information. But I would love to have a mechanism through which outside physicians can reach out to us much easier than having to find somebody that somebody knows somebody, in that way.
I think, Chris, your points are very well taken, and you're right. We try to expand our reach and make it easier for our friends and colleagues in the community to reach out to us. And there's some initiatives, to your point, through our website, also individual contacts that we, as you said, they have our cell phones, our emails. Try to expand that paradigm and have more of us, having that opportunity to connect with colleagues individually and through newsletters. We try to simplify it, make a directory, for example. It will be ideal
Mhm.
both for colleagues and community to reach us and vice versa, for us to reach them. So definitely agree with you in those efforts. And in that regard, I think, the journal clubs that you mentioned, opportunities for conferences and meetings and CME educational events is a great chance for us to connect with colleagues in community. And I know you guys are doing plenty of them, and you and your colleagues participate in many of those educational events. Chris, the other question for you is talking about, you mentioned before a lot of patients with younger age, lung cancer, non-smokers, which is a risk factor, and of course we provide resources for tobacco cessation. Tell me a little bit more about why we think we see these younger patients, and what are your thoughts about the future state in lung cancer treatment?
Yeah, I think that's $1 million question, right? So there was an interesting study more than 5 years ago in New England Journal of Medicine that showed some data to show that in the younger patient population with lung cancer in their 30s and their 40s, that there is actually a higher incidence of lung cancer in women compared to men for whatever reason. And this is more of a recent observation. So the question is, what's happening, at the epidemiologic level? Are there some risk factors that we haven't identified? I don't have any answers, and I don't think we have an answer as a community there, but it's definitely something we need to pay attention to. Now, one good thing is that the smoking rate in the United States is going down, quite a bit, and which is great. So the lung cancer incidence is coming down. Um, but at the same time, as a result, the proportion of never smokers or patients who have minimal smoking history, like I smoked a little bit in college and I haven't touched a cigarette since, those are patients who are still getting lung cancer. We see quite a bit of them. So I do think it's gonna be a larger patient population that will be coming to us. So really trying to understand um, what are the risk factors. And I'm not an epidemiologist, but I think that's definitely something we need to invest in. The other thing is, we also know that these patients tend to be immunotherapy refractory. And so understanding why are they immunotherapy refractory, are there strategies that we can develop? And I think Hutch is really um, poised to be able to answer those questions, and we have the expertise, we have the history. So I think we can really tackle those questions. So in the decades to come, those are the areas that I think we need to really invest, and also those areas that I think Hutch can really contribute.
Absolutely, Chris. I agree with you. I think the talent that we have here in the lab based science, translational science, epidemiology, and of course, clinical research, all those constituents, I think, can help us understand better why this phenomenon is happening: environmental pollution, microbiome, genetic factors, all of the above. It's interesting to me how we see this across tumor types, to your point, Chris, younger patients, and of course we always try to help them and the families. And talking about genetics, I know that lung cancer is usually environmentally triggered, environmental risk factors. Any comments about genetic predisposition to cancer, Chris, and how we work with genetics counseling team?
Yeah. So, lung cancer has always been thought of not being a genetic disease. That said, there are families that have been identified that have predisposition to lung cancer, even though they never smoked. Now, in smoking lung cancer, it's very difficult to tease out genetics versus smoking risk because smoking is such an powerful risk factor. So, but in never smokers, I think it's easier to see that. So it's specifically for patients with EGFR mutated lung cancer, there is a familial um, aspect of lung cancer that is EGFR specific. So the story is very compelling in that, I have patients who say, my mom never smoked. She died of lung cancer. I have a sister who's getting a workup for a nodule. So those are the family, types of family histories that makes me um, feel that we need to investigate further. And I have a handful of patients who have germline mutations in EGFR, and so they definitely exist. And there's also described families with lung cancer, even if there is no specific uh, genetic abnormality that's been identified. So I think there's definitely there, especially those within never smoking patient population. So we do tests for genetics, especially if there's family history.
Thank you, Chris. Very, very helpful to hear your points. And the other, question I have for you is we have a lot of amazing people here in a multidisciplinary fashion. I think about, thoracic oncology, and I think about, stars like you in medical oncology. We have radiation oncology, we have surgical oncology, thoracic surgeons, we have pulmonologists, nutritionists, so on and so forth. Psychological support, social workers. Tell us a little bit about the infrastructure of the multi and interdisciplinary team for thoracic and head and neck oncology.
Yeah, so it's interesting in that lung cancer tends to be, or had tended to be, a single discipline type of um, discipline, mainly because most patients were being diagnosed at later stages. Now, with the advent or continuation of CT screening, low dose CT screening for those who are at risk, we are seeing more early stage patients, and hopefully we'll be continuing to see more early stage patients. So really the multidisciplinary approach is becoming extremely crucial, especially with systemic therapies expanding to early stage more and more. So right now we have very close interaction and relationship with radiation oncology and thoracic surgery. One of the challenges that we are physically in different campuses. So our discussions are mainly virtual at this point, but we do meet very regularly. For our thoracic program specifically, we don't have a multidisciplinary clinic per se. Um, for many different reasons. Part of it being that we're all in different campuses, but that's something that we're kind of revisiting and seeing, does it make sense for us to all be on same place? But we have, still been able to provide a seamless care for patients. For example, our thoracic patients who get chemoradiation, their radiation is done at the University of Washington main campus. The medical oncologists were here at the Hutch. What we decided to do historically and for many years is that patients would get their chemoradiation as well, including chemotherapy, on the main campus. And because there is a chemo suite there, so that patients don't have to come back and forth, and we have physicians going over to UW main campus. So we have found ways to work around the physical distances so that that the care is, seamless for the patients.
Thank you, Chris. And as you mentioned, the power is in this interdisciplinary approach, and you find ways to work with a team here and have all the necessary input. And to your last point, having these touch points with community and work with them too, as you said, is very vital. And the patients appreciate that opportunity for collaboration, communication. Christina, every time that we have fun, time flies, and I don't believe we're talking for 24 minutes. And
Oh,
I want to keep talking to you because you're always insightful. And I have to say, you meet the Greek today. Christina, to me, sounds a Greek name.
yeah, that's right. It could be anything.
Exactly. It's definitely ubiquitous, right? Maybe before we close very quickly, if you can summarize for the audience, a couple of statements about the future vision. How do you see in the next 5 years the lung cancer evolving, and how do you think that Fred Hutch is playing a role in addressing this important health problem?
Yeah. I think as a lung cancer field, we've had a lot of advances, and the question is, what are the next impactful changes, right? What's going to make a biggest difference? And personally, I think there are two things that's really going to be impactful. One is expanding our screening efforts, because we have the tool, but we just are not using it, and patients are still being diagnosed at the later stages. So what I'm hoping that we can do as a center is really put some investment and really put more effort into the early detection piece of lung cancer. I think we can make a big impact by doing that. And then the second impactful change I think will be important is really on the question of immunotherapy refractory biology, and really making sure that more patients are benefiting from these long-term responses. And as I mentioned before, I think Hutch is really well poised to answer those questions. And we're already doing that. We're in the beginning phases of exploring some of our hypotheses. But I'm hoping that in the next 5 to 10 years that we have expanded the proportion of patients that are benefiting from 20% to 50% and more and more. So that's where I'm really looking forward to.
Thank you, Chris. So for all you're doing, helping the patients, the families,
Mhm.
having a great team, addressing, the totality of the challenges that patients face. And I'm hopeful, for the future, we're going to have even more therapy options. In the present, we have many more compared to the past. So we're definitely doing much better, to your point, and we'll keep doing better in the future. So thank you for all you're doing. Thanks to your entire team. And thanks for your time today. It's exciting to have you.
Thank you so much. This has been really great.
And thanks to the audience for enjoying another episode of Meet the Greek here with the Fred Hutch amazing faculty. Stay tuned. Please like, subscribe. We're going to have many more episodes coming up. We're having a lot of amazing people to discuss, like Dr. Baik today. So thanks again for the audience. I'm Petros Grivas, Fred Hutch Cancer Center, University of Washington. Have a wonderful rest of the day.